back to this educational activity focusing on stroke risk reduction in patients with diabetes. I'm Silvio Inzucchi, endocrinologist from Yale University, and I'm back with Dr. Karen Furie, neurologist from Brown University, and Dr. Alice Cheng, another endocrinologist, but from the University of Toronto. Alice, we just heard your presentation, Guide to Effective Use of GLP-1 receptor agonists in people with diabetes who are at risk for stroke. A couple of questions just to pick your brain. I struggle with this in clinic. Obviously, the major attraction, other than the cardiovascular benefits with the GLP-1 receptor agonists, is their prominent effect on weight and significant weight reduction. So they are favored in patients with obesity, but there are plenty of patients with type 2 diabetes who are just mildly overweight. You know, the BMI may be 26 or 27, and some individuals may actually be lean. If you're going to be using these medications mainly for cardiovascular risk reduction or stroke risk reduction, do you have any concerns about using these medications in patients where weight loss is not a prominent issue in their care?
So I think to address that question, I'd like to remind the audience that by virtue of someone having type 2 diabetes, they have insulin resistance, they have a metabolic disturbance, they have abnormal adipose tissue. And even though our definitions of overweight and obesity are BMI based, that's not the best definition of thick adipose tissue or an adiposopathy, which is a big word. It took me a long time to learn how to pronounce it, but it's not really the best definition of adiposopathy. So pretty much anybody living with type 2 diabetes has adiposopathy. They have abnormal fat tissue, and therefore reducing that will bring with it metabolic benefits. So I think it would be a mistake to restrict GLP-1 receptor agonists to only those who have a BMI over a certain number. I think there's a lot of counseling that would need to be given to patients so that they understand that even those who, from a societal perspective, where they personally did not feel they needed weight loss, there is health benefits and metabolic benefits to that weight loss. So I think counseling them and their families, frankly, about that is going to be critical. But I think it is a mistake to actually withhold it from those individuals. Now, you want to watch how much weight loss and what they're comfortable with, and then also ensuring that they're still doing physical activity to maintain muscle mass and that they feel healthy. But I think it would be a mistake to actually withhold it from those who have the lower BMI, because they do have type 2 diabetes, so they do have abnormal adipose tissue.
And certainly if they start losing too much weight, you can always tweak the dose and use lower doses and titrate that way. The other aspect of GLP-1 therapy or any diabetes therapy is the risk of hypoglycemia. And I think you made a very important point in your talk about the adjustment of other anti-hyperglycemic medications. Certainly when we are thinking about cardiologists prescribing these medications or neurologists prescribing these medications, they may be a little gun shy in terms of not getting too involved in the diabetes management, but by themselves, these drugs don't lead to hypoglycemia. When you use them with other agents that don't lead to hypoglycemia, they won't exacerbate the risk of hypoglycemia. But the important point you made is the use of these medications with insulin or with sulfonylurea. So just review that for us again.
Sure. So I would encourage our colleagues who don't do diabetes day in, day out, just to learn the names of sulfonylureas. Insulin, you know. Learn the names of the sulfonylureas. If you see that on the list of medications and you're not so comfortable with it, then you're okay to maybe not start and suggest someone else start. But if you are to start, then look at their A1C. And if their A1C is above 8%, there's likely room for you to add this other therapy, the GLP-1 receptor agonist, and they're less likely to get hypoglycemia because they're starting higher. But if their A1C is below 8%, then you may need to reduce the sulfonylurea or the insulin. But again, if that's not a level of comfort, then that's reasonable to ask someone else to help. But for those who are not on a sulfonylurea, not on insulin, then there's no excuse, right? I mean, those are low-hanging fruit, if you will. Those are individuals you can add it and you're not going to cause a problem for hypoglycemia.
Karen, do you see a day where neurologists might be prescribing these medications for their patients? I know neurologists don't necessarily follow their patients long-term after stroke, as do cardiologists, but is this something that you see could happen, or is it simply going to be a recommendation to primary care to please consider one of these medications in their stroke patients?
I can definitely envision neurologists prescribing these medications. Neurologists prescribe anticoagulants, antihypertensives, drugs for dyslipidemia. I don't see any reason why these drugs would require a subspecialist unless it was a complicated patient. The side effect profile seems favorable, and so long as the guidelines support initiation after stroke, I could see this being widely adopted.
Big question for both of you now, something that I have struggled with in reading these trials, reading the outcomes from mainly the diabetes CV outcome trials, where stroke appears to be a strong effect of the GLP-1 receptor agonists. Do we have enough information to confidently use these medications in patients with diabetes after stroke, or do we need a specific stroke trial? Karen, you're a trialist. I'll start with you.
I don't think we need a trial. I think there's enough evidence just based on the effect in people with diabetes that these classes of drugs are beneficial for all vascular risk reduction, including stroke. However, as a vascular neurologist, I am very interested in drilling down on a stroke-prone or stroke population. I'd like more data on the ischemic strokes versus intracerebral hemorrhage. There are subclinical manifestations of cerebrovascular disease like white matter hyperintensity that contribute to cognitive dysfunction as patients age. Might these drugs affect that and therefore have an impact on cognition in later life and quality of life? So given the questions about how these drugs affect the brain, I would be particularly interested to see a trial in stroke patients.
Alice, what are your thoughts?
I think having more data is always interesting. I don't need it right now personally as a clinician to start utilizing the therapies. And personally, I really feel that we need to all do a better job of the implementation of the data that we already have. We have so many fabulous studies that have already been completed. And I always say that's thousands of individuals who volunteered literally their bodies to help answer these questions. And it's our job to use those answers. And I think that's an area that if I were to invest money in something, that seems to be the area that would be very worthy of investment.
The SELECT study results were recently announced, at least top line results, and apparently in just obese patients and overweight patients who have prevalent atherosclerotic cardiovascular disease, the use of semaglutide apparently did reduce MACE. Now, we don't know the components of MACE. Be very interested to see in this non-diabetic population whether this drug may actually reduce stroke as well. Well, we are out of time. Thanks so much, Dr. Karen Furie from Brown University, Dr. Alice Cheng from the University of Toronto, discussing with me today this really interesting area of diabetology and neurology, focusing on stroke risk reduction in patients with diabetes. It is a brave new world. We have so many more tools to improve the health of our patients with diabetes and cardiovascular disease. Thanks so much for joining us.
Thank you.
Thank you.